05S Attention Grabber. Ever wonder how a basic health screening saves lives in Tokyo, yet a festival crowd in India becomes tomorrow's tragic headline? 510S Credibility Builder. Walter Crane here, 24 years chasing health stories across continents, has shown me spreadsheets don't scream when they're wrong. 1015S Roadmap. Today we're breaking down Japan's ironclad checkup system versus India's hit-or-miss approach, meeting the families who pay the price, and uncovering which policies actually move the needle. 1530S Transparency Note. Just so you know, this story stitches together government datasets, boots-on-the-ground reporting, and a few name changes to respect real lives behind the stats. 3045S First Hard Fact. Metabolic syndrome, hypertension, sky-high sugar, spare tire around the middle, wonky cholesterol hits 22% of Japanese adults but a whopping 30% of Indians. Source: WHO Dataset 2022. A neon-lit Indian market pulses with drums and laughter. Strings of marigolds sway overhead as families squeeze past stalls. Then in a heartbeat, an older man in a worn kurta clutches his chest, stumbles, and drops onto the cobblestones. The crowd stops dead, gasps rippling through the lane. Paramedics arrive, kneel, and call it seconds later. The man never saw the warning, the narrator says, because no one ever tested him. Cut to Tokyo. Sleek chrome doors slide open for Mr. Sato, a 45-year-old office worker. He taps his company badge on a glass turnstile. The lobby glows like a surgical ward. A robotic arm whirs as it draws blood while a monitor spits out live cholesterol numbers. The receptionist hands him a full-color printout: waist size, blood pressure, glucose, lipids, all part of Japan's mandatory kenshin package. That packet isn't optional, the host reminds us. Since 2008, Japan's Specific Health Checkups program has forced screenings on everyone aged 40 to 74, no opt-outs. Source: Ministry of Health, Labor and Welfare Report. The camera glides across a hospital wall chart. Cardiovascular events are trending down. That dip isn't hype, the narrator insists. It's proof that catching problems early saves lives. Back in India, the same age group queues under flickering fluorescents, praying for a slot. The government's NPCDCS program offers free screenings, but barely a quarter of the target group ever get through the door. Source: NPCDCS Guidelines. A man walks out empty-handed, handed a slip that says "No test today," bureaucratic tape over a ticking time bomb. The host's tone drops. When checkups are optional, the poorest vanish first. He flashes a map speckled with red zones where metabolic syndrome jumped 15% after cities sprawled. Source: The Lancet Diabetes and Endocrinology, 2020. Each red dot hides a family just like the one we saw. Split screen now. Left side, a Tokyo nurse hands a patient a pamphlet on miso soup and steamed fish. Right side, a deli street vendor bags up jail by drenched in syrup. Food counts, the narrator notes, but without a system, even the perfect diet can't outrun a silent killer. Source: Nutrition Reviews, 2023. Policy close-up. Japan's law makes employers foot the bill and the government audits every clinic every year, the host explains. Skip the screening. You'll pay fines, and that keeps every prefecture covered. India's approach, by contrast, feels scattered. Pilot programs pop up, but no national registry means data go into silos and follow-ups vanish into thin air, the voice warns. The result: an epidemic creeping through neighborhoods unseen. Montage next. Tokyo trains, deli clinics, a lone physician scribbling on a clipboard. Still think one screening can't shift a country's health, the host challenges. Japan stays at 22% metabolic syndrome despite salt-heavy dishes, while India surges past 30% even as incomes rise. We circle back to Mr. Sato exiting the clinic, his report tucked under his arm. He stops at a vending machine, buys a bottle of green tea, and grins at the lens. "This isn't just tea," he says, "it's proof that a country can catch trouble before it catches you." The scene snaps back to the Indian festival ground, now still, the fallen man's family collecting his things. A distant siren wails, but the crowd disperses, unaware another heart might stop tomorrow simply because no one ever listened. Two nations, two mindsets, the narrator sums up. One keeps a promise to its people, the other gambles with their futures. Title card fades in. 3 ways Japan's health checks beat India's fragmented screenings. The Japanese health check routine, called kenshin, does far more than a simple lab trip. It's a law-backed, nationwide gauge of metabolic health. Back in 2008, the Ministry of Health, Labor and Welfare mandated that anyone between 40 and 74 get a yearly specific health checkup. Logging waist size, blood pressure, fasting glucose, and cholesterol, 4 measures that pin down the main culprits behind heart disease and diabetes. Source: MHLW Government Report. A sleek, glass-walled clinic in Osaka hums with low-key efficiency. Cut to Osaka, a busy kenshin hub. A nurse leads a 30-year-old office worker through a 360-degree health scan. The screen flashes blood pressure 120/80, HbA1c 5.1%, cholesterol 180. Risk score low. Gentle machine beeps blend with friendly Japanese chatter, highlighting how health numbers have turned into everyday background noise. Those data don't sit in isolated vaults. Each measurement streams straight into a citywide database that watches personal trends across years. If a number slips past the preset limit, the system flags it for a follow-up visit, diet advice, or a medication tweak. That closed-loop screen flag intervene acts as feedback, stopping metabolic risk from quietly building up. Dr. Kenji Tanaka, who heads Japan's National Center for Global Health and Medicine, walks us through the thinking behind the panel. Expert interview. Dr. Kenji Tanaka, director of Japan's National Center for Global Health and Medicine, outlines the metabolic panel's purpose in kenshin. We don't just test, we watch trends. One high reading, we step in. His tone is steady, mirroring a system that favors small steps over emergency fixes. According to the 2022 WHO data, Japan's metabolic syndrome rate is 22%, a number still notable but clearly below India's 30% source, WHO dataset. That gap isn't just numbers, it reflects how the two nations structure preventive health. In Japan, kenshin's mandatory status sweeps away many socioeconomic hurdles that haunt opportunistic screening. National health insurance foots the bill, and clinics sprout evenly from city centers to distant islands, so geography isn't a barrier. Plus, the uniform protocol guarantees a 55-year-old farmer in Hokkaido gets the exact same panel as a Tokyo exec. A map of Japan flashes red dots, each marking a local health center. Now look at India's National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke (NPCDCS). Its guidelines call for opportunistic screening in public sites, but coverage lingers under 25% of the intended group source, NPCDCS government program. Since the screening isn't mandatory, huge chunks of adults, particularly informal workers or rural folks, stay off the radar of the health system. A packed Indian clinic where a nurse balances paperwork as patients queue. India's patchwork approach spawns three glaring blind spots. First, data gathering is spotty, lacking a central registry, trends are guessed instead of measured. Second, follow-up is hit or miss, people who screen positive frequently slip through gaps because referral routes are thin. Third, equity suffers, affluent city dwellers can pay for private exams, whereas poorer neighborhoods depend on occasional public options. Japan's win isn't just policy, its food culture bolsters the medical safeguards. Research in nutrition reviews finds that eating more fish, soy, and green tea links to lower insulin resistance in Japanese adults. Source: Nutrition Reviews. Those foods packed with omega-3s and phytoestrogens dampen post-meal glucose spikes that fuel metabolic syndrome. Kenshin records the bodily impact of those diets, letting doctors credit both lifestyle tweaks and medical care for improvements. A plate of grilled salmon, edamame, and a cup of green tea pops up next to a patient's chart. In India, fast-track urbanization has pushed metabolic syndrome rates up about 15% among 30-60-year-olds, per a Lancet analysis. Source: Lancet. The shift from traditional grains to refined carbs and processed foods amplifies risk. The secret behind Japan's health miracle isn't tucked away in some sterile lab. It's humming right in the lunchroom, the classroom, and the hallway of an office. Dr. Hiroshi Tanaka, a senior epidemiologist at the Ministry of Health, leans over a spreadsheet charting waist circumference trends and says, "Our system isn't a one-off test. It's a feedback loop that rewrites daily habits." Back in 2008, Japan rolled out the Specific Health Checkups program, a law that obliges anyone aged 40-74 to get an annual screen for waist size, blood pressure, fasting glucose, and lipids. Source: Ministry of Health, Labor and Welfare Report. The numbers don't linger on a shelf, they zip straight to employers. Big companies get anonymized dashboards that flag high-risk clusters. By the following Monday, the cafeteria swaps deep-fried tempura for grilled salmon, and the vending machines on each floor flash a green healthy choice label above low-sugar drinks. One study of Japanese adults ties that dietary pivot, more fish, soy, and green tea, to a striking drop in insulin resistance. Source: Nutrition Reviews 2022. Even primary schools embed the same metrics. Starting at age 5, kids learn to read nutrition labels as naturally as they read kanji. Teachers run weekly body balance circles where students compare their own waist measurements to national percentiles, turning personal health into a shared conversation. The outcome is a nation where metabolic syndrome hovers at 22%, a number that, while still notable, stays well below regional peers. Source: WHO Dataset 2022. Contrast that with India, where the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke (NPCDCS) offers opportunistic screening in public hospitals, yet reaches under 25% of the intended population source (NPCDCS Guidelines). Rapid urbanization has sparked a 15% surge in metabolic syndrome among Indian adults aged 30-60 source. The Lancet Diabetes and Endocrinology 2020. Picture a 12-year-old girl in Bangalore, her BMI creeping toward obesity, fasting glucose flirting with pre-diabetes. A pediatrician hands her a pamphlet titled Lifestyle Change. Her family, already stretched thin by tuition fees, can't afford a gym membership. The nearest public park is a 10-minute walk, but safety worries keep it locked after dark. Her story isn't an outlier, it's the human cost of a fragmented screening network. While Japan's employers subsidize healthy meals, Indian households shoulder the full brunt of preventive care. Japan's policy playbook is simple yet ruthless: measure, inform, adjust. Every annual checkup creates a data point. That point triggers a cascade: menu redesign, classroom curriculum, even workplace vending choices. The loop tightens with each cycle, turning abstract risk into concrete, everyday decisions. India's current model, by comparison, is reactive. Screening is opportunistic, not systematic. Interventions arrive after disease has already taken root. The lack of a unified data stream means schools, employers, and local markets never get the same health signal that Japan's system broadcasts nightly. If Japan can embed metabolic markers into the fabric of daily life, why does India lag? The answer lies in governance structures. Japan's health law mandates compliance across private and public sectors, and the ministry publishes quarterly compliance scores that affect corporate tax breaks. India's NPCDCS, though well-intentioned, operates without enforcement levers, leaving coverage to the mercy of local budget cycles. The numbers speak loudly. In 2022, 30% of Indian adults met criteria for metabolic syndrome, versus Japan's 22% source WHO dataset. That gap translates into millions more at risk for heart attacks, strokes, and premature death. And the human toll is already visible. The Bangalore girl's future college, career, motherhood now carries a shadow of chronic disease that could have been mitigated with a single, affordable community gym or a school-run nutrition class. Japan's model proves that policy can turn a nation's diet into a public health weapon. By weaving health data into corporate menus, school lessons, and even the glow of vending machine LEDs, the country creates a self-reinforcing ecosystem that catches disease before it spreads. India stands at a crossroads. The same data that shows a 15% rise in metabolic syndrome due to urbanization could also power a new feedback loop, if the government tied screening outcomes to incentives for schools and employers. Imagine a Bangalore office where the cafeteria swaps sugary snacks for grilled paneer after a quarterly health audit, or a Delhi school where children learn to calculate their own body mass index alongside algebra. The infrastructure exists, the policy will not. The gut punch revelation is stark. Every year, thousands of Indian children like the girl in Bangalore are denied the preventive safety net that Japan delivers by default. Their bodies bear the early scars of a system that never asked for their data, never answered their risk, and never altered their environment. When a nation treats health as a data point rather than a habit, the cost is not just numbers on a chart. It is a generation of preventable illness, lost productivity, and broken families. The hidden playbook is clear: measure, share, act. Japan's health checks are not isolated exams, they are the pulse of a society that refuses to let metabolic risk fade into the background. India's next step must be to turn its fragmented screenings into a unified rhythm, letting every data point echo through schools, workplaces, and streets. Until then, the human cost will continue to rise, measured not in percentages, but in the silent suffering of children who never got the chance to be healthy. The choice is stark: adopt the feedback loop or watch another generation slip into chronic disease unseen until it's too late. Dr. Priya Mehta leans forward, her voice steady but urgent. Change starts with us. Demand those yearly checkups from your boss, push for better meals in schools, vote for leaders who put prevention first. India's metabolic syndrome numbers are brutal: 30% of adults, way higher than Japan's 22%. But this isn't some genetic curse, it's the system failing us. Japan's been running mandatory specific health checkups since 2008. Everyone 40-74 gets measured for waistline, blood pressure, sugar, and cholesterol, year after year. Catches trouble before it explodes into full-blown disease, saving lives and taxpayer cash. Meanwhile, back in India, the NPCDCS program tries to screen people when they wander into public clinics, but barely 25% of the right people even get seen. No wonder misdiagnoses pile up in cities where metabolic syndrome just exploded: 15% in adults 30-60. The numbers don't lie, we're hemorrhaging prevention opportunities. But here's the good news, we can fix this. 3 moves you can make today, no waiting for someone else to act. 1. Ask your boss for real health coverage. Push for an annual screening package like Japan's full blood work waste checks the works. And yeah, mention the money angle. Early catches cut long-term insurance bills by up to 20%. That's not theory, it's industry math from 2021. 2. Make school lunch plates smarter. Get school boards to copy Japan's plate: more fish, more soy, more green tea. Studies show these foods actually lower insulin resistance. Check the nutrition reviews dossier. Round up the parent-teacher crew and demand mandatory health fairs every semester. Kids learn healthy habits early and parents can't ignore the data. 3. Back the NGOs actually doing the heavy lifting. Volunteer, donate, or just spread the word about groups filling the NPCDCS gaps in poor neighborhoods. Post their wins online. Nothing scares politicians like viral success stories and angry comments. Do these 3 things and you're not just one voice, you're part of a wave. When workers ask for screenings, companies call in labs that end up serving whole towns. When schools serve balanced meals and host checkups, kids grow up expecting prevention as normal. When NGOs shout louder than the lobbyists, lawmakers finally open the purse strings. It's exactly how Japan flipped the script: methodical, universal, driven by hard numbers. Your daily nudge, whether it's a Slack message to HR or a PTA meeting, becomes part of the bigger push. Fragmented systems don't fix themselves, they get stitched together by people who refuse to stay quiet. Change isn't some distant policy sitting in a dusty file. It's the chat over coffee, the town hall petition, the GoFundMe page, the lesson in homeroom. Your voice, multiplied by neighbors and coworkers, can turn a hopeful stat into a living, breathing reality. So get off the sidelines, speak up, show up, join the movement already gathering steam. Let's make annual health checks the rule, not the exception. The future isn't some far-off dream, it's the next email you send.